At the outset, I would like to thank the WeCare team for giving me the opportunity. And I would like to also thank Chairperson Dr. Maulik Madam. She was my teacher, and we had interdepartmental endocrine meet during our KM days. Thank you, Madam. For the next 15 minutes, I would like to discuss regarding this topic, assessment of anterior pituitary function. So I will go through these headings. The basic concepts I would touch upon first, then evaluation of hypopituitarism, then evaluation of hyperfunctioning of the gland, and then pituitary adenoma evaluation. Let me start with a case. 45-year-old gentleman, abnormal behavior since 2 weeks and drowsiness since the last 2 days, and he was unconscious at presentation. On examination, there were no localizing signs. The plantar bilateral flexor, and he didn't have hypoglycemia. CT was normal. When the lab evaluation was done, there was significant hyponatremia. The sodium was 112. He had similar histories in the past also, 2-3 episodes of hyponatremia given by patient's relatives. And the endocrine evaluation showed low T3, low T4, and the TSH being normal. T3, T4 low, TSH normal. So we asked for cortisol level, 8 AM cortisol came low, less than 1 microgram per deciliter. Then the MRI pituitary was done, which showed an empty cella. So here is a patient with hypopituitarism presenting with hyponatremia. This is the importance of evaluating for anterior pituitary function even in patients whom they are not presenting with any endocrine symptoms or signs. So coming to the basic concepts, the normal secretion of the various hormones. We know the pituitary is under the control of hypothalamus. The corticotropes are under the control of CRH, corticotropin releasing hormone. The ones corticotropes will stimulate the secretion of adrenal glucocorticoids and sex steroids. Similarly, the thyrotropes are under the control of thyrotrope releasing hormone, and thyrotropes in turn will secrete TSH, and in turn will stimulate the secretion of thyroid hormones. Same thing with the gonadotropes. Gonadotropes under the control of GnRH, and they will in turn stimulate the secretion of estradiol or testosterone. And prolactin is under the inhibitory control of dopamine. The GHRH from the hypothalamus stimulates the secretion of stimulates somatotropes to secrete more and more growth hormone, and growth hormone will in turn stimulate the secretion of IGF-1 or somatomedins from the liver. One more very important concept we have to remember is the feedback regulatory system. We have very good negative feedback system as far as the pituitary hormones are controlled. Decrease in the level of one stimulating hormone will increase the other hormones. Best examples are thyroid hormones, cortisol hormones, inhibitory effects on the TSH axis, or cortisol on the CRH-ACTH axis. So this negative feedback mechanism maintains the hormone levels within a relatively narrow range. Positive feedback mechanisms are less compared to negative feedbacks, but increase in level of one stimulating hormone secretes the other hormone. The best examples are estrogen mediated stimulation of the mid-cycle LH surge and oxytocin release during childbirth. These are the examples for positive feedback systems. So order of pituitary hormone deficiencies when with hypopituitarism, usually it's like this: growth hormone first, then gonadotropes, then TSH, then ACTH. Corticotropes are the last cell to lose function, but it doesn't follow every time it's like that. Sometimes with especially the hypophysitis, even the corticotropes can lose their function first. So every time patient need not follow the same trend. So when do we suspect hypopituitarism? These are the conditions in which we should suspect hypopituitarism: unexplained hyponatremia, infertility, unexplained vomiting. In fact, in my last 15 years, I have seen at least some 5-6 patients referred by a gastroenterologist just for vomiting. So when evaluation, resistant vomiting going on for the last 2 to 3 months, found out that there is hypopituitarism, both cortisol and thyroid function being very low. Vague symptoms after traumatic brain injury. This is one very, very important field. It is found that in some studies, 20 to 30% of the patients with the traumatic brain injury, especially the basal skull injury, will have hypopituitarism in the long run. So that is the reason it's very, very important to assess for anterior pituitary function following traumatic brain injury or even sometimes subarachnoid hemorrhage. So whom to screen the hyponatremias? Then one more thing, I will come to it in the next few slides. Disproportionately low T4 with normal or low TSH, then prior head or neck irradiation, traumatic brain injury, or skull-based surgeries, we are supposed to screen for hypopituitarism. One more, in our part of the country, coastal region, Kerala and Karnataka, history of snake bite. That is also one of the very important history. We have to go for screening for anterior pituitary hormones. Then hypothalamic pituitary mass lesions. Then newly discovered empty sella, developmental craniofacial abnormalities. These are the areas in which we have to screen for hypopituitarism. So coming to the clinical features, ACTH deficiency, whenever there is an acute condition like pituitary apoplexy, the patients can present with acute symptoms like vomiting, nausea, dizziness, hypotension or hypoglycemia. But chronic conditions, it's chronic hypopituitarism, it's very difficult to diagnose. The conditions are entirely non-specific. The tiredness, anorexia, weight loss, hypoglycemia, these are the various non-specific symptoms the patients might present with. Coming to growth hormone deficiency, short stature in children. In adults, it's very difficult. Abnormal body composition only. Gonadotropin deficiency, menstrual disorders and infertility in women, and decreased sexual function or loss of secondary sexual characteristics in men. TSH deficiency, again growth retardation in children, and features of hypothyroidism in adults. So this one slide I would like to highlight. This is because very important. So we get lot of thyroid functions. When we read thyroid functions, always if there is some problem, it's always better to repeat because lot of lab variations also will be there. But we have to remember this inverse log linear relationship between TSH and free T4 levels. Both, this is from clinical chemistry. Both immunoassay as well as tandem mass spectrometry based assays, we can see as the FT4 is coming down, the TSH increases disproportionately or significantly. So that is called as inverse log linear relationship. That is the reason whenever the FT4 is disproportionately low compared to the TSH elevation, you have to suspect pituitary cause or central hypothyroidism. So how to diagnose hypopituitarism? Coming to the evaluation, lab evaluation, we have basal pituitary hormone levels, FSH, LH, prolactin. If you have good machines, then you can go for ACTH also. The target hormone levels, the cortisol, IGF-1, FT4, testosterone or estradiol. These are the target hormone levels we can evaluate. But growth hormone axis and hypothalamic pituitary adrenal axis, most of the times we require dynamic testing because the baseline values will not give us the proper diagnosis. So these are the baseline investigations which we can ask whenever we are suspecting hypopituitarism. For all practical purposes, cortisol, FT4 TSH, the prolactin, FSH LH, testosterone or estradiol will be sufficient because the IGF-1 will be a little expensive. If there is suspicion, then we can always ask for later. IGF-1 we can ask for later. So important thing we have to remember, whenever because of the negative feedback mechanism, whatever I have told in the past, the low levels of tropic hormones in the setting of low target hormones, always suspect there is something wrong with the pituitary. So examples, low T4 with the low or normal TSH, low cortisol with the low or normal ACTH, low testosterone with the low or normal FSH or LH. I'll give some examples. The T4 is 4.1, that's on the lower side, 5 to 12 being the normal. So what is the expected TSH? TSH, because of the T4 is low in primary hypothyroidism, expected TSH will be around minimum 40 to 50. So T4 of 4.1, we expect the TSH to be that much. Suppose if the TSH comes like this, 6.2, always think central hypothyroidism. You don't jump into conclusion, but always ask for other pituitary hormones as well as repeat the thyroid function again. Free T4 0.4, very low, 0.8 being the low limit of normal, so 50% less than the lower limit of normal. So we expect the TSH to be more than 100. Suppose in this patient TSH comes as 7.2. Even though the TSH is higher than normal, though it can be immunoreactive but biologically inactive. So that is the reason we have to suspect central hypothyroidism in such patients. 8 AM cortisol 3.2, lower limit of normal. So ACTH at least should be more than 60. But here if you are getting ACTH of 5.2, again we have to suspect central causes as adrenal insufficiency. Testosterone 1.1, the assays of testosterone was not good. So if the testosterone, if you are getting 1.1, you repeat it again, the morning sample. If still the testosterone comes as 1.1, then the LH, if it's coming low, 1.2 or FSH 1, whatever. So if you are getting low FSH or LH, then you have to think of pituitary cause as the cause of gonadotropin, gonadal deficiency, hypogonadism. Coming to dynamic testing, when the baseline tests are not enough to diagnose hypopituitarism, we have to go for dynamic testing, especially when the basal hormone levels are equivocal, especially with respect to growth hormone as well as ACTH deficiency. Co-syntropin test, 250 microgram IV of co-syntropin, and you can measure the cortisol after 1 hour. In case of adrenal insufficiency or pituitary cause of adrenal insufficiency, the cortisol will come as less than 18 microgram per deciliter. So for growth hormone stimulation, we have various tests, but the commonly used are clonidine stimulation test, 5 microgram per kg of clonidine, then growth hormone assessment at 0, 30, 60 and 90 minutes. If it is less than 5 nanogram per ml, suggests any value, less than 5 suggests growth hormone axis insufficiency, or any value more than less than 3 suggests severe growth hormone axis insufficiency. So these are the conditions with hyperfunction. I will not go into the details, but I will just touch upon these areas. So here is a case patient coming with the striae and puffiness of the face, hypertension. So clinical suspicion was Cushing's disease. So how to screen for Cushing's disease? First do 8 AM cortisol, basal cortisol, to rule out exogenous administration of glucocorticoids. Then do overnight dexamethasone suppression. Give 1 milligram of dexamethasone between 11 to 1, and the next day morning 8 AM to serum cortisol. If it is more than 1.8, suggests possibility of Cushing's. Then midnight cortisol, then 24-hour urine-free cortisol, then low-dose dexamethasone suppression tests. These are the tests we can go for confirmation of endogenous hypercortisolemia. So then once the endogenous hypercortisolemia is confirmed, then you can do basal ACTH to rule out whether it is a pituitary or ectopic ACTH induced Cushing's or adrenal disease. So MRI or CT neck, all these things will help in the further diagnosis. Coming to the growth hormone excess, acromegaly. So the IGF-1 is the first investigation. So if the IGF-1 is high, you can always confirm with the PGGH, 75 grams of oral glucose, growth hormone after 1 hour. If it is more than, growth hormone is more than 1 nanogram per ml, it suggests growth hormone excess. Coming to case 3, the 26-year-old lady, amenorrhea since 1 year, infertility, galactorrhea, prolactin comes as more than 360, on dilution 6000 plus. So this is the MRI, large pituitary macroadenoma. So it was a macroprolactinoma. So we have to beware of this high dose hook effect. Whenever there is a strong suspicion of pituitary macroadenoma or prolactinoma, so if you are getting the prolactin low, so because of the galactorrhea, infertility, amenorrhea, we are strongly suspecting prolactinoma, but the prolactin level comes low, it can be due to oversaturation of antibodies, the hook effect. So always we have to test the serum in dilution. Coming to the pituitary macroadenoma evaluation, whenever there is a pituitary macroadenoma because of various other reasons, probably visual field effects or some other reasons, MRI done showing pituitary macroadenoma, how to evaluate? So here we are suspecting the hypopituitarism because of the compression effects. So always do hypopituitarism evaluation, 8 AM cortisol, free T4 TSH, FSH, LH and prolactin. These are the hormones we have to look for when we are evaluating pituitary macroadenoma. Last case, there is an incidentaloma sitting there. Incidental finding, evaluated for headache. The MRI showed an incidental pituitary adenoma, less than 1 centimeter in diameter. So how to evaluate? So it's very unlikely to produce hypopituitarism. This very small microadenoma very unlikely to produce hypopituitarism. So look for hormone excess. So you can do ODS cortisol, overnight dexamethasone suppression cortisol, prolactin, FT4 TSH, FSH-LH testosterone, and if there are clinical suspicion, you can go for IGF-1 also. So concluding my talk, high index of suspicion is very much essential to diagnose pituitary dysfunction. Accurate diagnosis is very, very critical. Lab values always should be correlated clinically, and baseline and dynamic testing for anterior pituitary hormones is very helpful in the diagnosis of pituitary dysfunctions. Thank you.